Hi, I'm Angie Smith.
And I'm David Johnson, speaking to you today from the UNC Lineberger Comprehensive Cancer Center in Chapel Hill, North Carolina.
We would like to thank BJU International for selecting our work to be featured as Article of the Week for its August 2014 issue and giving us the opportunity to present our work today. We'd like to briefly describe our study, which evaluated whether neoadjuvant chemo for bladder cancer was a predictor of postoperative complications, length of stay, or operating time after radical cystectomy for bladder cancer.
Clinical guidelines recommend strong consideration for use of neoadjuvant chemo for muscle-invasive bladder cancer based on level 1 evidence for a survival benefit. However, despite these recommendations, neoadjuvant chemo remains underutilized for a number of reasons, one being the concern that the treatment leads to increased complication rates following cystectomy.
In a randomized trial by Grossman, postoperative complications of patients who did or did not receive neoadjuvant chemo were compared, and no difference in incidence or severity of complications was noted. However, assessment of complications was not an objective of the study design.
Contradicting the results of this study, another multi-institutional study from the IRCC database looking at over 900 robotic cystectomies reported that receipt of neoadjuvant chemo was an independent predictor of overall as well as major complications. However, complications were captured retrospectively.
Recognizing these conflicting results in the literature, we sought to investigate this question using data from the National Surgical Quality Improvement Program, also known as NSQIP, which is a program through the American College of Surgeons in which complications are specifically and systematically captured within a 30-day window.
We determined eligibility for neoadjuvant chemo based on renal insufficiency, with creatinine clearance less than 60 milliliters per minute. Excluding those patients ineligible for chemo, we found that 12% received neoadjuvant chemotherapy, consistent with prior studies examining chemo utilization. As you can see from the top of Table 2, there were no differences in complication rates between the two groups, with those who received neoadjuvant chemo having a complication rate of 55% compared to 52% among those who did not receive this treatment.
On multivariable analysis, with results noted in Table 3, we found that neoadjuvant chemo was not a predictor of complications, reoperation, wound infection, or wound dehiscence after controlling for multiple covariates.
Furthermore, we found no difference in adjusted operating time or length of stay among those who did and did not receive neoadjuvant chemotherapy.
This study is important as it utilizes prospectively captured surgical complications, providing a comprehensive view of morbidity following surgery. Despite this, it is limited by several factors, including the inability to evaluate pathologic stage, as well as information regarding the chemo regimen or number of cycles.
Nevertheless, our study contributes additional evidence that neoadjuvant chemo given before cystectomy does not lead to increased postoperative complications, operative time, or length of stay, contradicting a belief that likely hinders appropriate use of multimodal therapy.
Our study therefore supports existing guideline recommendations for strong consideration of neoadjuvant chemo before cystectomy for muscle-invasive bladder cancer. Further efforts are needed to improve patient and physician awareness of the benefits and tolerability of neoadjuvant chemo in order to increase its utilization in appropriate settings.
We would like to acknowledge our collaborators and funders, and we thank you for listening.